I'm Greg Jica from the University of Kentucky, and I served on the CTF in the Clinical Diagnosis Working Group, co-chaired that with Cindy Carlson. But really, the work bringing UDS4 forward came from you all and a lot of hard work put in by the CTF. I think many of them are thinking about empty nest syndrome. What are we going to do now with our Friday mornings if this all works as smoothly as planned? So we have a great session this afternoon. I'm really looking forward to it myself. First, we're going to have a short video taped by Jessica Culhane that's going to go back over the pilot survey results and timeline. I think that's important because I'm really excited about the next session. Suzanne Schindler will lead that from Washington University. Suzanne has pulled together with NAC four representatives from 4 different centers that participated in the pilot, and we're really going to get their insights, and that'll be open for Q&A. So for sites that did not or were not able to participate in the pilot, here we're really going to learn from each other. So I'm really looking forward to that. I'll let her introduce the panelist when she comes up. We'll have a very short, I believe, update on the neuropsych battery from Andy Sakin of Indiana and Lisa Barnes from Rush. And then we'll close out the session with technology work group updates from Sudeshna Das and from the Massachusetts ADRC and Sarah Biber from NAC. So thank you all for being the holdouts. If we get a congressional bonus, maybe we should all sign a sheet and be first in line for additional reparations for sticking through the whole meeting. So thank you all. And with that, we'll get started with Jessica.
Hi, I'm Jessica Culhane. I'm the research team manager at NAC, and I'm going to be sharing more about the UDS4 pilot feedback we received. First, a huge thank you to all of the ADRCs who participated in the pilot. Your feedback has been so helpful for NAC and the CTF. And in addition to improving UDS4, during the pilot, ADRCs also gained experience obtaining IRB approval for administering the new forms to participants across cognitive statuses, collecting and submitting UDS4 data with new electronic data capture and submission tools, and using some of our new documentation and training materials. Now, to show you some of the feedback that we received, so it was challenging for some sites to obtain IRB approval in time for the pilot, but 16 of the 23 participating sites were able to get approval to administer the new forms to participants, and 1 more site tested the form with mock participants. Each site was able to pilot the forms to somewhere between 1 and 5 participants for a total of 55. And one focus when setting up the pilot was ensuring that centers didn't just pilot the forms on unimpaired participants, who are obviously the most likely to agree to sit through an additional UDS visit. The sites were successful at getting participants with both normal and impaired cognition to complete the pilot. And as discussed in the NAC session, we made a number of resources available to pilot sites to help prepare to pilot the forms. So most everyone watched the virtual training webinars from May, where the CTF walked through forms that had significant changes in detail. These are still posted on the NAC website, and we intend to keep them available. Not as many people use the coding guidebook, which is really intended to be both a coding and a clinical tool. And some sites commented they didn't know that the guidebook was available. And then about half of pilot sites use the ADRC program community forum on Discourse. So overall, people found these resources really useful. The coding guidebook has been revamped from UDS3 to be more helpful. And we noticed a number of answers to questions in the feedback were actually included in the guidebook. So once we release the final version to the ADRC community, we really encourage you to check there first for answers. And the ADRC program community forum on Discourse got some really positive comments. People really enjoyed having a centralized place to get answers to their questions, and we'll be rolling that out to the wider community soon. We asked about the time required to administer the forms and also to transition to UDS4, and this really varied across sites. Part of the reason for that variation in administration time is that these were piloted on a max of 5 people per site, and centers already varied widely in version 3 administration time. So we're seeing that in V4 as well. So here we're showing the average time sites reported to administer V3 visits in dark blue, and the additional time needed to administer V4 is in light blue. 2 sites actually reported no increase in administration time from V3 to V4. So for them, the efficiencies introduced on the forms fully canceled out any additional time due to new forms or questions. This is another way of looking at the same data. So we can see that like this site with the 8-hour administration time is an outlier, but there was on average a 1-hour increase in visit time. There were several comments that it was worth having a longer visit in order to collect this new information, but the panel coming up next will be discussing ways to reduce administration time. The amount of time that sites anticipate they'll need to fully transition to UDS4 also vary quite a bit, but most centers reported they'd need 6 months or less. We also requested feedback on form content, and this gave us some insight into what's driving the increase in administration time, as well as areas of confusion for sites trying to administer these new forms. We asked pilot sites how easy it was to administer UDS4 forms, focusing on the actual content of the forms, and 12 of 17 respondents were neutral to positive, but a few sites found it difficult, and their comments were really helpful to point out some areas where we need to make tweaks to the forms or provide additional training. The CTF and NAC reviewed all of the pilot feedback, and here are some of the actions we're taking to address common feedback. We're going to collect IRB application language from those who completed the pilot so we can collate them into a helpful resource. The CTF will provide guidance on which forms sites can send to participants and co-participants in advance and how to do that. CTF is making edits to forms A1A and D1B for brevity and clarity. They're also clarifying guidance in the coding guidebook for many forms, including the social determinants of health, which, as I mentioned, it should be your first resource for answers to questions. DSM-5 criteria for psychiatric conditions was introduced on the health history form and D1A, and the CTF has additional live training planned, walking through case studies with the criteria. There were several comments on needing a video training on Form A4A, which is the ADRD specific treatments. That training does exist from the May clinical webinar, and the link on the NAC website's been fixed. So thank you for alerting us to that. In addition, as Sarah discussed in the NAC session yesterday, we're implementing a 6-month start window for the transition to UDS4 to account for the varying amount of time that sites anticipate they'll need to complete the transition. So for the sites that are ready to start implementing UDS4 right after the final forms are released, they're welcome to do so. If sites need a little extra time, they can keep administering V3 visits until the final start date. Finally, a plug for the UDS4 resources available to sites to start preparing for the UDS4 transition. It's on the NAC website, and we've got this QR code at the UDS4 booth as well. Come and visit us. Thank you for listening, and please feel free to reach out with any questions.
All right, and now welcoming to the stage Dr. Suzanne Schindler of WashU ADRC to kick off our pilot panel with a short presentation.
All right, so you just heard about some of the quantitative data on the pilot study that 23 centers participated in. Now we're going to hear about some of the quantitative data, the comments that people had about the UDS after administering it on their participants. Can I have the next slide, please? Next slide. So as we heard from Sarah Bieber and others in the NAC session, the plan is to start implementing the UDS in January. And we think it's important that people start to implement it right away and not wait a few months before they get going. And I will talk about some of the reasons for this, but it may actually take a while to get this up and running. So please don't delay, start right away. Next slide. So another thing that I'd like to emphasize is that the UDS-4 is different, and we think that it will add a lot to the evaluation of our research participants. It does seem like it will take a little bit more time, at least initially, but we think it's worth it. And I think this is mirrored in the comments from the sites that participated in the pilot. So I'm just going to read some of these comments. So first of all, they commented that most of the forms were relatively unchanged. And so the sites were able to pretty quickly understand how to fill these out. They thought that some of the forms had better branching logic, so they were more efficient. Some sites noted that the forms take longer because we're collecting new data, but that this data was really important, like on social determinants of health. And jokes aside, so apparently people are making jokes about us, but all of the existing materials and documentation have been really helpful throughout the past 18 months or so. So thanks to the NAC team for providing all of this information. Next slide. So a common theme that we heard from several sites, and again, this is a reason not to delay, is there were issues getting IRB approval. So do not underestimate this process. Don't wait till March to file your IRB documents, because this can take a long time. And the sites were telling us that working with the IRB for the pilot really prompted them to think differently about the implementation of the UDS-4 rollout. So please start working on this very soon, or you may not make it to get this up and running before the deadline. Another common theme that we heard is, yes, we're giving people resources and training, but that each site really needs to have their own internal trainings and guidelines that are more detailed and specific to their site. And the sites that participated in their pilot said, after this experience, we are planning more site-specific staff training to ensure that their team is ready. Because although, of course, we did these workshops and have these resources, this didn't really tell them how to actually administer the UDS-4 and how to handle these potential questions. And these sites are now planning to have extensive training regarding these new forms or protocols, especially some of these new forms, the social determinants of health form in particular. So again, this is going to take some work, and I would not underestimate what you need to do to get this implemented before the deadline. Also, there's some new concepts. So the subjective cognitive decline and mild behavioral impairment. It's important that the staff members at your site understand what this means and how to apply these criteria. And we've also heard from multiple sites that some of these questions that we ask on the social determinants of health form are pretty personal, and some people feel uncomfortable answering them. And there's a feeling that there needs to be additional training on how to administer these forms and deal with potential reactions to some of the questions. It's also important that the sites consider logistics, including scheduling. One side said, we realize that UDS4 implementation will need to be a very carefully organized series of events. I think that's correct. And we plan to take the next few months to integrate the UDS4 into our current processes and site-specific data collection processes as well to look for efficiencies and reduce redundancy. We will coordinate all visits as though they are initial visits. Yes, you should. And in some cases, they need to add more time for these visits, especially for clinicians and also for consensus meetings. So this is going to take a fair amount of work, at least initially. One really bright spot in many of the comments was that the tech team has really done a great job. And really the sites were pretty universal in thinking that the REDCap system was working very well, and that the forms were very well designed, easily imported, that it was easy to enter this into the REDCap database. So great job, tech team. There were some additional requests for guidance and resources. We heard in the NAC session about some of those resources and how they're being provided. Things like a crosswalk between UDS3 and UDS4, checklist of items that need to be completed, and there's some requests for some additional training materials, and we are trying to fulfill those requests. You saw these slides earlier, but this is just showing some of the resources that have been made available to help with this transition. And here's a summary slide of this. I think the point is that NAC is here to help you if you have questions. So I'd like to acknowledge the clinical task force, particularly Cindy Carlson and Greg Jica. And then NAC has really had an incredible team putting all of this together, including looking at all the results from the pilot study. So Sarah Biber, Jessica Colhane, Catherine Gothrow, Elise Gruber, and Hannah Rosentreter. So I think they all deserve a hand for all of their work. All right, so I briefly summarized some of the comments, but what's much more interesting is to talk to people who actually participated in this pilot. So we're going to have representatives of 4 different ADRCs talk to us about what the UDS4 is really like. So I would like to invite Campbell Sullivan and Eric Steinberg to join, and then we have Justin Barber and Nicole Oliveira joining us virtually. All right, so I think that I wanted to start off with Campbell. So Campbell, should sites wait till, oh, and here we have on our screen, Justin and Nicole. Thank you for joining us. So starting with Campbell. Campbell, should sites wait until April to submit their IRB?
Absolutely not.
And why not? What was your experience with your IRB?
We are sort of your warning sign. So we submitted pretty shortly after we signed up, and it took weeks and weeks. And we only got IRB approval 2 weeks before the study ended. So we had very little time to find, we found a single participant who just really loves us and loves to come in and do testing. And we're able to complete that. But yeah, it was challenging. So I know not all IRBs are created equal. So some are going to be very efficient and very good and get it done quickly. But I would just plan for worst case scenario and submit as soon as you possibly can. So.
I like that. Plan for the worst case scenario. Okay, so next, let's go to a different contrast. Nicole, so my understanding is your site got up and running pretty quickly. So can you please tell us about what you did to make that happen, and in particular, how you trained the personnel at your site to get this going?
Yeah, so our IRB didn't have any issues, which was nice. It was a pretty quick turnaround of a couple weeks, so we were able to quickly get participants in. We do have a cohort of about 510 people, so we have a lot to pull from, and luckily we were able to find 5 very eager participants to get up and running. We did an in-person training that day of the webinar where we all sat in a big room and watched the webinar together, which was really helpful because we were able to ask questions in between each session and talk about how it would apply to our site. That was really helpful, and we plan to do a similar thing. Now that we have the go live date, we're going to be doing a similar kind of large group luncheon, like day-long training, where now that we have more guidance on UDS before, we're going to do mock participants and practice the forms with each other. We're also going to have clinicians kind of practice forms with coordinators as mock participants, especially with the new DSM-5 criteria and the new clinician forms. Our site, I was the one who did all of the pilot visits. So I worked in REDCap first, and we started by I started by printing out all of the forms and doing it by hand first before even entering it into REDCap. And I think that was really helpful so that we just learned how to get the questions done, work through the forms before also having to learn REDCap. So that's kind of what we're planning to do with the training as well, is having people just learn the forms, learn the paper forms first, learn REDCap separate, come together and learn it together. And combine the two. So that's kind of what we did. We broke it down into just different forms, and it's going to be a lot of practice with mock participants with each other.
Well, that's great. Thanks for sharing with us how you managed to do that. So the next question is about the DSM-5, and I'm going to ask Eric about this. So one way that UDS-4 is different is that we are now trying to be more rigorous about, for example, what we call depression, and rooting these diagnoses in the DSM-5. But many individuals at our center aren't necessarily familiar with the DSM-5, what those criteria are. How has your site dealt with learning these criteria and applying them?
Yes, as you can hear me okay. We are going to be creating checkoff sheets. And for each diagnosis that is in the D2A5 form, for each psychiatric diagnosis per DSM-5 TR criteria. And our plan is to have quite extensive training on DSM-5 TR criteria. And to be able to talk about individual participants after they're seen to make sure those criteria are correct, that criteria is correctly met.
So you're not just relying on your staff to learn by themselves the DSM-5?
That is correct. I mean, we have been using DSM-5 TR criteria at our consensus conferences, so it's not a completely unknown concept. But we want to more rigorously use these criteria for our, dealing with psychiatric conditions, particularly in the D2A5 form. So it's something we will put effort and training into familiarizing staff with the criteria for each individual psychiatric diagnosis, considering having a checkoff sheet. And then as we begin to implement UDS 4.0 evaluations, to also assess how well it's working and feel confident that correct criteria is being met or being met accurately.
Okay, that's great. And one follow-up question. So another way that UDS-4 is different from UDS-3 is we have this concept of mild behavioral impairment. Do you feel pretty comfortable with that concept now? Do you have questions about that?
Sure. Actually, at our center, where we have a tremendous emphasis on CTE, and actually this is something, MBI was a concept we will be using very frequently and significantly, because many of our research participants with a history of repetitive head impact have mood and behavioral neuropsychiatric symptoms. So to be able to accurately document that in the diagnosis form would be very helpful. And I think it will require some more training and to truly be able to implement during consensus each concept. But I think we feel fairly comfortable with the MBI criteria.
That's great. So my next question is going to be for Justin. So Form A1A, the social determinants of health form, is brand new. And Justin, can you tell us about your center's experience in administering this form? So for example, who administered it? How long did it take? Were the participants concerned about the questions? Did they think they were too personal and didn't want to answer them? What was your experience?
Yeah, so I administered 2 of them myself, and then 2 other study coordinators administered to other participants and caregivers. And so the way that we approached it and had planned to approach the A1 and A1A going into the pilot was that we would give a general spiel about how these are really important things for understanding and research and understanding how they affect the outcomes that we're all interested in understanding better, and the diseases we're interested in curing, pardon me, and then kind of let the participants just handle it on their own. We instructed them that we'd be out in the hallway or in the next room, and if they had questions, they could come to us, or we could just revisit them at the conclusion of completing the survey. I will add that we had 2 demented participants completed with a caregiver, and then 1 MCI participant completed on her own, and then 2 cognitively intact participants completed on their own. And those with impairment all took 23 to 25 minutes, and those who were normal all took about 15 minutes. The caregivers gave some good feedback about maybe if there was a way to split those questions into subjective questions and the more objective questions, so that the demented patient could answer questions about how they feel about being safe in their neighborhood and things like that, whereas they would just be guessing on things about, for example, the income level and those sorts of questions. So we found that some of that feedback very helpful. Yeah, and nobody had any concerns about any of the questions being too personal or invasive. There were a few items that were responded to with the do not want to answer. And then I did note in two of the 2 demented cases, both of the caregivers gave sort of this impression that by answering all those questions, it kind of gave them this perspective on their life that they felt they didn't have before, because they didn't always consider some of the socioeconomic disadvantages that others might experience. And so that was kind of a thing we were not really expecting to hear. And so that was a neat bit of feedback as well.
Great. Well, thanks so much. Do any of the other panelists have comments about administering Form A1A, the social determinants of health form?
Yeah, I found our participants very much enjoyed, we found, completing that form. And many of them, actually, we got good feedback, they felt it was about time that we begin to ask and collect data on social determinants of health. They saw the purpose, the need, and were very willing to participate. In some cases, it brought up different issues in people's life. For instance, in terms of discrimination, we got some feedback that they felt perhaps there should be some questions regarding feelings of remote discrimination earlier in their life versus how they're feeling now. But there seemed to be felt an acceptance and willingness to answer the questions, and a genuine feeling that it was something that's necessary, and they're very happy to participate.
Okay, great. Campbell?
And I think our team reported back, our individual was more advanced in the disease process, so probably at a CDR2. And so there was no discontinuation. And so just sort of giving that feedback to the team, that when you have someone who can't necessarily answer the questions on their own, and their caregiver may not be able to do as well, having that discontinuation, I think that was the biggest feedback. But personally, I'm very excited to see the data, and I'm very happy that it's been added to the UDS. So thanks.
I think we feel the same way. All right, so my next question is for Nicole. Another brand new form is Form A4A, which records whether participants have ever received disease-modifying treatments for Alzheimer's disease. Did anyone have confusion about how to complete this form, or was it crystal clear?
It was really straightforward for us. Of our 5 participants, one of them was on active Leqembi infusions, and so we got to actually go through the entire form with them, and we didn't encounter any difficulties. I believe that one I recorded originally on paper and then later put onto RedCap, and I had no issues asking the questions. The participants had all of the information available. I do think it's a form that if we know participants are on active infusions, we should, when we maybe confirm the visit, tell them to come with some of the information, like their start date and things like that. The study partner of the participant is very organized and has a folder with all that information that they came prepared with, without me prompting that. But I do think that looking at other participants, it might be helpful to just prompt them to come with that information. But the form itself was very straightforward, and I felt like the webinar and information we had was very useful.
Well, that's great to hear. So my next question is for all panelists, but I'd like to start with Justin. So I think a major concern that people may have about UDS4 is that it takes longer. So a couple questions about this. Do you think this is just a learning curve, and that as you do more of these assessments, it'll go a little bit faster? And another question is, what strategies did your center use or think about might be useful in making this more efficient?
Yeah, absolutely. Those are important issues. And we tried to think of some of for the second part, we did try to think of some of these things beforehand, but we ended up just wanting people to answer all of the new forms themselves in person in the visit, so we could then talk through it with them afterwards. But we're planning ways to now, in collaboration with the DMS core here, to capture these data beforehand, maybe integrating it into our hybrid survey platform that we use with RedCap. And so there's lots of opportunities for that we recognize will really help make these visits shorter, in terms of primarily for Form A1 and A1A in that case. But then when it comes back to the first part of the question, Dr. Schindler, the learning curve we found was mostly in asking some of those new health history questions. Our center's done the UPDRS all throughout UDS3, and so that wasn't anything unfamiliar for the clinicians. And then some of the data inputting took them a little bit longer, but that's because we have our DMS core builds and maintains a specific data capture system for us. And so there was also a different system there to contend with. And I think that'll just, my experience in talking with the clinicians, which we have APPs, MDs, and DOs, is that it just takes a couple visits to get through those new sets of questions until we understand how to best answer those. And for the to dovetail with the previous question you asked, Nicole, about the A4A form, we've put together a brief reporting system for generating a summary of any disease-modifying therapies an active participant might have been on, so that the clinician can cross-check that with what is discussed during the visit, just for completeness, essentially.
Great. And let me follow just one question. So we've made pretty extensive modifications to the medical history form, so A5D2. We've added a whole bunch of questions. What did you think of the questions we added? And did you have any difficulty kind of administering those? So we ask about things like cannabis use now. We ask about women's health issues. Do you think those questions were pretty well received by the participants, or were some people not happy about some of those?
In our experience, there wasn't any issue with those added questions, and I think we kind of couched people on that going into the visit, that there would be some additional health history sorts of things for them to answer. It's just my personal sentiment in talking with the participants that I've known over many years, that the women liked that there were some added questions in regard to their health histories. And separately, talking to other participants with histories of TBI, I think that the new TBI questions will be easier for them to answer, I think, and also easier for us all to use. And then a lot of the other items are some that we already collected, but those are, I don't think, what you're asking about, like about pulmonary issues and things of that sort. So I think that's the best answer I've got from you for you there.
Okay, that's very helpful. And let me actually jump over to Eric for a minute. So you talked about how your center is very interested in TBI, and your center did provide input on those new questions. Do you feel like those questions are pretty helpful to your center in better capturing TBI?
Actually, yes, and I believe some feedback was provided by iCenter in creating those questions. Mm-hmm. So, yeah, I do think it will be very helpful.
Great. Yeah. And did you have any comments on the length of time that UDS4 takes to complete? Have you thought as a center about how to make this more efficient? Do you have suggestions?
Sure. You know, so I'm dating myself here, but I was around for the implementation of UDS 3.0, and a lot of these same concerns were expressed then, but now we have some advantages. Most of the red cap forms are created. We're used to the forms, the existing forms. So most of the emphasis is on the new forms and the few additions to the existing forms. So I think a training would be very helpful. I think practicing these forms. I think just efficiency comes with experience. And as we begin to implement these forms and working with research participants, we'll see issues that arise and we'll deal with them as they do. But I think I'm confident that with some time, you know, we'll build efficiency. You know, and I think training, organization, planning, and our plan is to have a training period where we're practicing these forms, and all of our staff to review the NAC training modules, where they've begun to do that. But putting all of that together, I do think we'll become much more efficient.
Yeah, Campbell, please.
I will say, I mean, we added tests. Like we're changing the battery. It's evolving. This is sort of this like living document, and it's getting more sophisticated. And I think that is a good thing. But you know, we've added a list learning task, and we've added these really important SDOH forms, and we're being more sort of sophisticated in how we're collecting, you know, health history. And I think overall, when I look at the battery and I see sort of what our team did and what I expect, I imagine it is going to add some more time to a typical UDS visit. But I think the benefits and the data that it's going to generate sort of outweighs the burden. And I think so I wouldn't be surprised if your site might take a little bit longer to do the visit. And I do think with practice, we'll get more efficient, but ultimately it's a longer battery, so.
And Nicole, what do you think about how to make this as efficient as possible? Have you talked about, for example, sending A5D2 to participants before their visit, or the social determinants of health form? What sort of things do you think would make this go faster?
So we've considered possibly sending some of the red cap forms ahead of time, but it's not something that our site does right now. So we're unsure if that's something we want to pursue or if we're just okay with longer visits. Like Campbell said, it just is more forms and it's more or questions on existing forms. So we've just accepted that they're going to be longer visits and that's okay. I think the first couple months will be especially long just as we train on it. And we also know that the first year doing these initial visit packets are going to be longer than the follow-up years as well. So knowing that this first year is going to be a bit of an extra burden, but that as it goes on, as we train, but also as we then get to do follow-up packets and starting in 2026, the burden will ease a little bit lower. I think there's small parts that we can find ways to be more efficient, just like we have with UDS3, but at the end of the day, it's just more forms and we're okay with just having longer visits in order to collect the information that we need.
Okay, great. Well, and then one other question, so just a broad general question for all of the panelists. So, so these centers need to implement this soon. What is your advice on how to go about this process? What advice do you have on when to start? The trainings they need to do, those sorts of things. How to make use of the resources that we've provided. I know that some of you have already used those resources. Campbell, do you want to start?
Sure, I'll start. I think the online resources are really pretty incredible, and the fact that there was this, I guess, the discourse, and our staff could, text in questions and have answers immediately has been really helpful. I think the training modules that are available are really helpful, and just sitting down, with your team, and like you would implement anything else or any other, modification that seems to, I think that will benefit everyone. My biggest thing is, if you have a challenging or pokey IRB, get started now.
All right. How about Justin? Would you mind going next? Your advice to the centers?
Yeah, I think you should start the whole process as soon as possible, whether it's on the regulatory IRB end or just in getting staff trained and comfortable with some of the new materials, even if they may not be using them right away. Also, with the consensus process, you may want to begin practicing or running those through. I think it's important to, if you're not already, to consult with the boots on the ground, so to say, whether it's your coordinators, social workers, your psychometricians, whoever it is, the people that run the visits day to day. I think that's essential. And also, our experience in the pilot and just in any time our center has made a change independent of NAC to the visit process, whether that's changing the way that we process blood samples or provide that sort of feedback or something, we've always told participants that up front and let them know in advance so that they can have that mindset going into the visit that year, that it's going to be longer for X, Y, and Z reason, or this thing that they were accustomed to before is now going to be something different than it used to be. And so I think that would help as well. And those 3 or 4 things are probably my main recommendations.
So we need to warn the participants. So one thing that you mentioned was the consensus conference. Can you talk about how that has been how that worked for UDS4, how that was different than for UDS3?
So for us, it will be a change in identifying those normal cases that we've always identified as through the local forms that we capture about subjective memory concerns, and now putting them into a different bin than just normal. They are normal with subjective cognitive decline. And then also the impaired other now being up to 4 categories. And so that has always been a kind of a process we've done anyway. And so it was nice for it to all be set out for us. We were able to make the sort of decision tree diagram on how to handle those cases. And then for MBI, that I think will be where the most confusion or learning and sort of obstacles that we have to overcome as a consensus group will come from. And in terms of splitting D1 and D2 into splitting, or D1 into D1A, pardon me, that's kind of something we always did. Who we would determine what the clinical status was, whether they're normal MCI or impaired or demented, and then what does all the collective evidence say the etiology would be. And so that was kind of natural for us to have that split up of A1 or D1 and D1A.
So it sounds generally like this is a lot of the thought processes and overall processes you've already had. It's just a little bit more nuanced.
Yes, I think that's fair, and it's helpful to have some of these new parameters for those sorts of cases that will fall into the subjective cognitive decline bucket. Whereas in past years, there may have been some debate between the neuropsychologist and the neurologist if this was MCI or early MCI or not, as well as those cases where there's DSM evidence based on DSM criteria for a major depressive disorder and how to classify those participants. So I think those things are all of the possible combinations of those things that will arise will be new for us, and we'll kind of handle those as we go, but we hope to do it as a group so that we're educating everyone on the staff at the same time, whether it's the most expert neurologist or the brand new intern that knows nothing about degenerative diseases. So.
Yeah, so some more buckets. So this should make our consensus conferences more exciting. All right, Nicole, what is your advice to the centers for, you were very successful in getting up and running fast and getting your participants through. You talked some about how you did this, but anything in particular that you would advise the centers to start doing now?
Practicing the new forms, especially like the SDOH, the new health history form questions, and just being prepared with pushback on the answers. We didn't get a ton of pushback, but there were a couple hesitancies. And it's just a little bit awkward when it's your first time encountering someone who might be a little uncomfortable with answering the question. So I think just practicing the form ahead of time so that you are confident about why you're asking these questions, explaining why SDOH is so important to collect, why these health histories are so important to collect, and being confident in your reasoning for that and making the participant feel safe with answering those questions. I think that was the biggest thing, and that will be our biggest thing moving forward is practicing how to ask questions and how to ask follow-up questions with these new forms and guide participants through the uncomfortable question and answers. I think that's the biggest thing. And of course, the IRB approval. I think we had prepared our IRB submission quite a while before, knowing that it was coming up, so we kind of submitted it very quickly. But yeah, I think beyond just the logistics of it is really the practicing the new forms and practicing how to make a participant feel comfortable answering the uncomfortable questions.
Okay, so practice, practice, practice.
Yeah.
Like, all right. So Eric, so you were telling us that you survived the implementation of UDS-3. Do you think we're going to survive the implementation of UDS-4?
I have no doubt.
And having survived the implementation of UDS-3, what do you think the next year is going to be like, and what guidance do you have for the centers?
Yeah, I think, UDS 3.0 obviously was new. There were new forms. I agree with all of the advice that's been given, starting early, introducing the forms to the staff, practicing the forms, choosing a date that you're going to officially start, perhaps having goals between when you start introducing the forms to when you'll begin having sub-goals, so everybody feels comfortable with the new forms, everybody feels comfortable with the new added data entry. I think starting early with the IRB, we were fortunate we were able to get the pilot study approved pretty quickly, but I always find introducing the concept of the IRB early is very, very helpful. And, you know, and reviewing all the NAC training modules, which I agree are wonderful, have been very, very helpful. And, you know, like with 3.0, it all came together, preparation, you know, practice. But I would agree not to delay.
Yeah. But it sounds like it's all going to be okay.
Yeah, it will absolutely be fine.
All right. I'm glad to hear that. So, all right. So we have about 5 minutes left in the panel. Does anyone have any questions for these folks who participated in the pilot? Looks like Greg's coming up with a planted question. So
not a planted question, and it just kind of popped into my head, you know, listening to the 4 different sites give experience. I am concerned about, you know, the uniformity with which all of our individual testers and clinicians apply what we've put together. And so I was just wondering, you know, like the neuropath group is putting together these CPCs, just wondering whether or not case vignettes for training or perhaps sites that are very early up might be able to video some of their consensus conferences, de-identify data, and that could be a valuable shared resource. I don't know what the panelists think, but I'm just thinking about, you know, how do we get everybody to approach all the forms, all the questions in the consensus process in as close to a way as possible so that when we're done, we have a basket full of apples rather than a basket full of fruit salad.
Boy, that's a big question, Greg. I think maybe we should have the clinical task force steering committee work on that. I don't know if you have any comments, but.
I mean, I really like the idea. I think it would be a lot of work, but ultimately very beneficial. So yeah.
Okay.
Hi, Sandy Weintraub from Northwestern. Can you give us a heads up on what your IRB didn't like that in UDS4 that was not in UDS3?
So I will preface and say it wasn't anything in particular about UDS4 that they had trouble with. I think we, in our effort to be efficient, gave them several things simultaneously. Some of it was like Spanish language at a different site and stipends, and I think it was just sort of like sorting through all of that at one time was just slowed down the process. So they didn't dislike anything.
Thank you.
And are they kind of pokey anyway?
I mean, it's South Texas, so yeah. We're a little bit slower.
I have 2 questions, but just wondering if anyone thought there was anything missing that you wish we had, because I guess there's still opportunity to do.
Oh, Nina, please don't ask that.
No, I don't mean items. I mean like resources.
Oh, okay.
Sorry.
That's okay.
I have heard tell that there's going to be, from Brad Beauvais, there's going to be a video on UPDRS and training the neurologists and our postdocs on how to do that. And I think that would be very welcome. So, but I hear it's in the works.
Yes, I've heard it's in the works. Please.
Hi, Diane.
Oh, sorry, Eric, I cut you off.
I was just going to say, I think what will be very helpful also as we begin to implement is having the availability to get quick feedback from the task force on issues and problems that we're experiencing. So,
well, we'll put Greg's phone number on the forms, the bottom of the forms.
Hi, Diane Jacobs from UC San Diego. So in terms of resources, again, I'd like to echo what everybody said about how NAC's done a really good job with pulling together some really useful resources. And I'd like to put in a plug for the coding guidebook, which I actually found incredibly useful, and I'm shocked that 9 sites managed to do the pilot without using it at all. As I trained staff, I really went to it as the source of truth for how to complete the form. So use that as a resource. And also regarding resources, I would encourage maybe NAC as a potential clearinghouse or warehouse as sites develop processes and forms that they're doing supplementary, like Eric mentioned, they are doing these DSM checklists to maybe share them with NAC, to share with sites, so we're not all creating these resources independently. Thanks.
Nina?
My second question was, and I don't know if this group of 4 necessarily has a comment on it, but earlier it was pointed out that some sites had site-specific training or issues related to the UDS4, and I was wondering if there are any examples of those, just curious.
Sure. Anyone briefly want to mention any site-specific trainings if you have any? If not, we can skip that, but okay. I do recall that you had like a checklist for the DSM, so that's kind of a site-specific sort of thing. And then I think maybe Justin was mentioning that there was a list of ADRD treatments, maybe? So it sounds like some sites are making some resources. So it might be good to tell us about those, because I bet that other people could make use of those as well. So, all right, just one more question. Go ahead.
Yeah, Charlie DeCarly from UC Davis. So this is the 3rd or 4th time that DSM came up about depression. I'm just wondering, that's a clinical decision made by the physicians generally. I'm not sure how that's being conveyed, because it's presuming that some other staff are making this diagnosis. I just want to get clarity, because for us, it's the physicians making the diagnosis.
At our site, we have case consensus, and that is comprised of a neuropsychologist and a neurologist, and together we are agreeing on the diagnosis.
We only do that at a consensus conference. And
yeah.
So is it physician training you're talking about? Because I just a little bit
so to clarify,
uncomfortable with how that training might be done. Like psychometrists may have this insight, but it's a clinical diagnosis that should be retained by the physicians in the consensus conference. So forgive me if I don't understand that.
Yeah, and just to clarify, are you talking about a history of depression and A5D2, or are we talking about the final diagnosis?
Both.
Or both, yeah. Well, I think that's a good question. I think for A5D2, this is largely based on the participant report. So they're telling you what they've been diagnosed with in the past, and to some extent you have to kind of believe what they say, whether it's about, kidney disease or depression for the
And that really doesn't involve DSM-5, because if you ask a participant, oh, was that diagnosed by DSM-5? 99% of the time they're going to say, what is DSM-5?
Yeah.
So I think this is related to the clinical diagnosis. And I don't quite understand what this cheat sheet that you're talking about, because I want to make sure that we're communicating to our staff that this is a physician-based diagnosis.
Yeah. Well, I promise that I will ask to talk about this at our next CTF meeting. And actually, we are a little bit over on the panel, so I think we're going to have to. Did you
actually,
have a
just
quick?
Really, actually, as a comment more than anything else, Chad Murchison, University of Alabama at Birmingham. So we've talked a bit about the idea of sharing resources and things like that as individual sites get up and running. This is just kind of a cheap plug for the discourse forum that had been mentioned earlier. Like, we are not going at this alone from all this. So as you find things that work and resources and materials that have benefited your center, or if you're running into unforeseen complications, please let us know. That is going to be an excellent central repository to be able to have these kind of discussions and try to make this as smooth as possible for everyone.
Okay. Well, thank you so much. Well, thanks for all the questions, comments. Thank you so much to Justin and Nicole for joining us virtually, and Campbell and Eric for joining us in person. Can we give our pilot participants and pilot sites a hand?
Thank you.
And I'm glad it's all going to be okay.
Thank you so much. Now, I'd like to welcome to the stage Dr. Andy Sakin of Indiana ADRC to talk about the UDSB4 neuropsych battery updates.
Hi, everyone. On your program, it says we have 30 minutes for this, but Lisa Barnes and I, as co-chairs, actually asked for 5 minutes just to have some space for the cognitive battery. I think and first of all, I'd like to also just again congratulate everyone from NAC, Bud, Sarah, the whole team, and the CTF and everyone else involved in bringing these developments as far along as they are now. It's just terrific to see that. For the cognitive battery, the design principles have been well, I think, articulated previously. We covered that in the May webinar, which goes into much more detail. So fortunately, in this case, we retained most of the UDS3 cognitive battery, so there's little change. The VCOG or TCOG, the telephone or preferably video versions going forward. And then, of course, there's the addition of the Ray AVLT or the CERAD verbal learning component that were also covered in some detail, and all the forms, of course, and manuals are available. The other additions are the digital speech capture that Rhoda O told us about in describing the future, and it's really the present. So we strongly encourage all of the centers to do digital recordings. The issues of privacy, security, transformation to de-identify data that Rhoda spoke about earlier are issues that are very much a work in progress, and look for updates on that from Rhoda, NAC, and others going forward. There's a manual. I know there was a booth in the back that hopefully many of you visited that had information about digital technology and the best practices, which were also posted. So watch for further developments there. Some of the other issues are, how we're handling practice effects and the issue of alternate forms. And basically the issue there is the CTF committee plus the cognitive working group plus several statisticians who joined us and the entire team really debated the issue of alternate forms, and a decision was made we would use one form and model practice effects statistically. There were differences of opinion. That was the consensus decision going forward. And in the future, we anticipate there'll be new digital cognitive measures. Maybe we're talking about UDS5 for that, but watch for opportunities to collaborate with other centers and groups and do pilot studies. This is the test battery order. This has been shown previously, and you have these materials. Just one more slide here. There's a few issues that have emerged from the feedback that we received during the pilot study and beyond. So one is the order of administration. There are some site-specific issues, and the decision was made to try to be flexible and allow centers to, tweak the order slightly if necessary. We would prefer that things are done as they are in the protocol. But if there's a need to slightly move things, that's acceptable. The issue of forms, because we are using the same form and NAC set up data capture for the specific test items and these specific word lists and forms, we are not permitting alternate forms or changes in administration. Yet the recall and recognition for both the Ray AVLT and the CERAD were made flexible in the sense that some centers were using one or another form of recognition, and we accommodated both. So there's a NAC capture for those, and that's all in the materials, and there's clearly a place to check off which form was used for that. But the lists themselves are standardized for use across centers. The other issue that's come up is what about the delays, which of course differ between the Ray AVLT at 20 to 30 minutes and the 5 minutes for the CIRAD. The principle here is to use only non-interfering material. Since they're verbal memory, verbal learning, using visual materials would be fine. Maybe other forms that need to be filled out that wouldn't interfere, so we would encourage that. Other issues, the Spanish and Chinese forms, as you know, are works in progress. That was discussed earlier today. And the UDS3 is available until there's a new UDS4 translation. Finally, watch for some enhancements in terms of quality control and algorithms that may capture errors and help for more accurate coding with some of the tests. There's some work on the Mint in that regard. And in general, we would just really encourage you to continue to send feedback and questions in. We'll bring them to the cognitive working group or others in the CTF as needed. And I think that is just about 5 minutes here. But feel free to reach out to myself or Lisa Barnes or other members of the cognitive working group. I know Sandy Weintraub is here. Mary Sano, I think, just had to leave. Suzanne Kraft and Rhoda O. So we look forward to hearing from you, and thank you very much. I think we turn it over to the last part of this session now.
Yes, thank you, Dr. Sagan. We are now turning it over to Dr. Sudeshna Das from Massachusetts ADRC and Dr. Sarah Biber from NAC to give the CTF Technology Workgroup updates. This section of the agenda actually is 30 minutes.
Hello again. All right. So we're here to talk about the CTF Tech Work Group and provide some updates. So at NAC, when we think about data, we like to think about applying standards to data. And right now, digital data is a little bit like the Wild West. There's a lot of different types of digital data collection that's happening out there. Technology is rapidly evolving. Many heterogeneous concepts. Many are collecting data, and there are few, if any, standards. So in an attempt to take this on as a program and a NAC, we recently, Rhoda Al and myself, along with Nina Silverberg and others, recently reimagined our CTF Tech Work Group. So some of you may be aware of this change, but we have recruited some amazing subgroup co-leads to lead several different components of this work together. So that includes work focused on in-clinic UDS digital instruments. These are like the buckets we have created to think about this kind of work. Virtual standard UDS digital instruments and new non-UDS digital instruments. So each of these groups has developed a charter. They are starting to think about some early deliverables that they want to accomplish together, and you'll be hearing more about this over the coming months. So one initiative that we took on together was to launch a digital pilot award. So I want to once again congratulate Jeff Kay and Joseph Weiner on being the first recipients of the NAC Engage Digital Pilot Award Program. So that is our first partnership with Gates Ventures, and it was a very successful one. We had a lot of interest in this program. We opened it up to individuals basically anywhere could apply if they formed a team with at least 2 ADRCs as part of it to propose a new kind of digital data collection for the ADRC program and to pilot that. So we're very excited that these projects are now underway and are looking forward to seeing the outcomes of that work soon and then looking at how we can scale that further across the ADRC program. So Rhoda mentioned earlier that digital voice is coming. It is optional, but she, I thought, made a very great case for why this is going to be a valuable data modality for everybody to collect across the ADRC program. And this is something, as she mentioned, we've been working on together. So, we have formed a UDSV4. We decided to start with something really concrete with regards to digital data. Let's figure out how we're going to standardize UDSV4 digital voice recordings with a neuropsychological exam. As Rhoda mentioned, there's a number of different ADRCs, including the 14 ADRCs that are part of the LEAD study, that are already collecting digital voice data. So that is a fantastic start. They've been doing that successfully. There's a lot of things we need to consider here as we think about both collecting and then, of course, sharing, standard QCing, harmonizing, and sharing this digital data. And we're going to be thinking about those things as part of this digital sprint team, as part of the CTF work group. We encourage all of your thoughts. We need to proceed very carefully as we think about this new data stream. But essentially, we're looking at things like how do we ensure data security, how are we going to navigate de-identification, how are we going to do things like quality control, as well as consider things on the governance side in terms of IRB's consents related to data sharing. So we're thinking about all of those things. We have a really incredible sprint team that we've pulled together. We're looking at other international initiatives that have done this kind of work and what strategies they've used to try to learn from how this can be done most effectively. And those are all things that are underway. So there's actually, we haven't talked about this much, but there's a lot of tools that have already been put together that are available for your ADRC to go check out on our website. So here's like the 100th QR code of the meeting. You can click on that code to check out these digital voice resources that this team has put together. So that includes a digital voice startup checklist. So that checklist is intended to be used much like our UDSV4 checklist and our SCAN checklist. We really like checklists at NAC to really walk ADRCs through the process, right, of getting going with digital data collection and to connect them to all the resources that they need to get that up and running. We've developed IRB and consent language that you can go to your IRB with to help get approval for this kind of data collection. Once again, learning from LEADS and other very successful studies in this space. And then we've also put together a digital voice collection manual, and that manual guides ADRCs in the process of collecting, storing, processing audio recordings of the UDSV4 cognitive exam. We've developed some guidelines around that. We're not going to, can't fully standardize it, but we want to have some, some guardrails on there so we can make sure that this data is data that we can combine from across the ADRC program effectively down the line. So it's, once again, not required to capture this data, but is strongly encouraged and is something that we'll be tracking as we go forward. So I want to thank all of the members of the Digital Voice Sprint team, so you can see here, who have been involved. This has been a great collaboration, including one of my new colleagues, Trevor Cohen from University of Washington, who has been involved in helping us out with this. And I want to especially thank Brittany Hale, who has really done an amazing job of pulling together a lot of these resources. So another exciting thing that we're thinking about as we think about things like digital data and also other new kinds of data that we're pulling together at NAC is how can we get more of the global research community, right, excited about using NAC data, bring new people to the table, right, to use this data. And so one concept that we're really excited about is community challenges. And so there's a number of the way that these work is that you pose questions that data scientists can answer, and answers are only known by the organizers, okay? So we might ask a question like, who can develop the best algorithm to predict who's going to transition from normal cognition to mild cognitive impairment in the next few years, right? And you can actually launch a challenge around something like that with data. And so these challenges have facilitated a lot, have a great track record facilitating unbiased improvements in machine learning in many fields. So we hope that we'll be able to run challenges like this in the future using digital data, and that we will facilitate kind of new kinds of open science using NAC and ADRC program data. So SAGE, not safe, BioNetworks and Kaggle have platforms for building and evaluating machine learning. We're also strategizing around a potential challenge in collaboration with ADDI around digital data like this and other data modalities. So we're really excited. Just want to kind of tease this idea. This is something that is coming. If you're interested in getting involved, we'd love to collaborate with you. In addition, right, as we think about the massive increase that's happened in global utilization of ADRC program data, right, I showed you a 228% increase, and we look at how to increase that over the past 3 years in average number of monthly data requests. This is a mechanism we can use to drive even more traffic to NAC data to derive new and important insights. We're really excited about this as a tool. All right, I'm going to end there and pass off to Dr. Das.
Thank you, Sarah. So I'll be talking about digital voice, D-Voice, which is an optional UDS instrument. And again, like the ATN form, and as Dr. Ravinovich mentioned, the only things you'll get are like gold stars and leaderboard on NAC, but yay. And so this whole project is, of course, Dr. Rhoda O's project. I'm simply lending my voice. Conveniently, my last name is Das, so I'm the D-Voice of Dr. O's D-Voice project. So why D-Voice? So as our cognitive abilities evolve, there are subtle changes in our vocal expression which can reveal underlying changes in the brain. And these shifts may be expressed in linguistic patterns, such as like word choice, sentence structure, or like speech patterns, such as like words per minute. And you saw from Dr. O's presentation this morning, there was a great example of like how the pauses or the words per minute were changing as like cognition was declining. D-Voice can be used as a tool for like early detection. There's a growing body of literature that indicates that, and Dr. Rhoda like presented a lot of those examples. There's also Dr. K at OSHU who does that. And voice can also be used as a digital biomarker for clinical syndromes and etiological diagnosis. So, there's work done by Dr. Dickerson at MGH, and who also leads the lead study and using voice to distinguish from people with like PPA, PD, ALS, and so on. And there are many benefits of like D-Voice markers. So the first and foremost, it's a low cost and inclusive instrument and really easy to get. And to really like hone in and say like how that is, my mom, who lives in India and is cared for by by people, her caretakers, forget about like tech literacy. They're not literate, right? But they're able to use their smartphone, use a WhatsApp app, and she sends me like digital voice recordings of herself as well, like giving me status updates as well as of my mom, right? So this is really a low-cost solution that can work, globally. It has minimal participant burden. The neuropsych testing is already being done. And of course, there's a little bit more burden on the administrative staffs and the RAs who are administrating it. But we hope this is worth it. Again, being Rhoda's voice, and this is just like collecting blood. Let's get this data, and as the tools evolve, and hopefully lots and lots of good science will come out of it over the years. It's also used as a quality control tool, and I know that the VCOG study uses this, and many other sites may be doing it, where you're digitally recording these voice tasks, and then go back and do a playback to act as a QC tool to determine if if these test results were being captured properly. And finally, as novel analytics tools comes up and NLP and advanced AI comes along, there's like an unprecedented opportunity for us to mine this data. Yes, AI, I'm a big fan of AI, and just wanted to put in a plug for AI again. Nobel in physics and chemistry goes to AI. Okay, so AI. I had to sneak in there, sorry. And but digital voice is not new. There's lots of precedents here. There was a survey, technology survey by the CTF Technology Work Group in fall of 2023, where like 18 ADRCs said they were already collecting digital voice during their cognitive assessments. 8 ADRCs said that no, but we do plan to collect this in the future. And 8 ADRCs said that no, we have no plans for collecting this data. And of course, there is Rhoda's Framingham study, where she's been like one of the pioneers to introduce digital voice. The lead study, ADNI for Dementia Bank, is an international study where voice biomarkers and analytics have been around for quite some time. So the CTF technology work group, D-Voice Sprint team, yes, put a lot of like tools and resources for the ADRCs to help capture voice data. So first of all, the first hurdle to cross is the IRB protocol, right? So the protocol has like 4 components to it. One is the objective. So in the protocol, make sure that you are clearly stating the purpose of the study and the role of the audio recordings in achieving your study goals. Then you get into the details of the procedure, what will be recorded, what's the setting and the method for the audio recording, and the detail of the equipment that you'll be using for doing the recording. The storage, again, make sure you describe that the measures you're taking to protect participant confidentiality and having all the privacy and the security taken care of. And finally, you want to have some material in there which specifies like who will have access to the data and who will the data be shared with. So we put together some examples from like various studies, like the LEAD study, for example, which Brad graciously shared with us. So in the LEAD study, for example, here is here in red is like it says what will be done in the study. So it's as simple as like a recording device, like such as the Olympus digital voice recorder or a similar digital recording device will be used, right? And then it gets into also how the data will be stored. So here's another example from the iConnect study led by Dr. Hiroko Dodge. And they're describing it as like the iConnect video chat system is a secure, scalable, and cost-effective video chat platform for conducting in-home telehealth with geriatric populations. It enables researchers, clinicians, and older participants easy access to private meeting spaces at the touch of a button. Like a clear description of the study. And again, I've highlighted some other things like it says it facilitates joining video chat services by automatically entering required join commands for subjects with 1 click. And users have 2 UI options, join or restart. And down at the bottom, you can see they say that all the recordings are stored in HIPAA-compliant, institution-supported cloud resources. Next, another part of the IRB is the informed consent. So again, that has like 4 different components. It has a purpose, so clearly explain the purpose and the reason you're collecting this audio recording and how this recording will be used. You want to touch on confidentiality, which is important, describe how the recordings will be kept confidential, and the measures in place to protect the participants' privacy. Data sharing, like specify who will have access to the recording and who will it be shared with. And also in the informed consent, you want to explain the benefits and potential risks associated with the audio recording. Again, I'm leaning on the LEAD study and the iConnect study to give example. So here for their informed consent, it clearly says, we will audio record your responses to some of the memory and language tests. And recording your responses will allow researchers to write out your responses exactly as they were spoken. These recordings and transcription will allow researchers to analyze your responses in order to answer important questions about, and I'm highlighting this such as because you want to give examples rather than make the language very, very constrained, such as behavioral markers of speech, language, and decline. So clearly states what is being done and why it's being done. So then in terms of confidentiality, it says your recordings will be maintained on secure servers used for this study, and only those with privacy training and permission from the study team will have access to the data. Here's different one from the iConnect study. So from the informed consent, this is the part that I extracted. It says all video chats will in this study will be video and audio recorded. Part of the testing will also be audio recorded. And so will the weekly phone call, and we'll use those recordings, again, purpose for educational materials and research analysis, right? And we'll protect your privacy when sharing the audio recordings by only sharing it with like approved researchers. So it's people who sign that with the data use agreement will not share it any parts of the audio that contain identifying information. So again, like Rhoda mentioned, that you could splice out like the PII, the personally identifiable information from it, and any other information that could leak your identity. But however, it informs the risks. However, because the person's voice is unique, it's possible that when someone's listening to the recording, they could identify you just from your voice patterns. But again, Rhoda shows us examples of tools that can be used for like de-identification of the voice itself. So finally, like many of your IRBs will require an additional consent, which means that at the end of the consent, it explicitly asks the participant, do you give us permission to audio record your responses to some of the memory and language tests? Yes or no? And then this additional consent is required if the audio recording is not an essential part of the study, which it will be for the UDS v4 because it's an optional form. So the sprint team also put in a lot of protocols and like how to collect devoice and preferred methods and guidelines. So such as like turning on your Zoom recorder, record the staff name, the participant's ID, their visit information, date and number, and their neuropsych test name. And other things like make sure there's limited background noise and record the participants' responses and the recording, store, and upload to NAC. Seems really easy, and we want to also keep some like flexibility on, like some sites might want to record each individual test separately, or others might want to collect all the tests together and then splice out the different tests. So then once the data is collected, then there's some processing that might need to be done locally, like splicing out the personally identifiable information. De-identification tools are not going to be the responsibility of the ADRCs, but rather, centrally we'll be using de-identification tools and masking and splicing out the personally identifiable information before this data is shared with any other researchers. Again, so this will be done centrally, and it's not going to be, the burden's not going to come on to like the individual ADRCs. And again, just want to reiterate that, like blood, again, I'm Rhoda speaking, this data we just want to keep collecting it, and NAC will not share any of this data until all the de-identification processes are validated and complete and everything is in place. This data is not going to be shared with everyone, right? And so there are some other tips we put together, mostly Rhoda's team at BU, about like naming conventions for the files. So keep it simple, just the participant ID, the date, and the test name, preferably stored in the WAV format. But again, we want to give flexibility so that we can get as much data as possible, and hoping that all these new tools as they come in, we'll be able to use like lower resolution formats and still get the data that we want to get. And then finally, for submission, so a few of us got together and designed the metadata for the UDS D-voice form. So this is just like a little sneak preview of the digital voice device metadata that we are thinking of. So some of these things are like obviously you want like the subject's identification, their visit date, number, the cognitive testing that this is recording, some timestamps if like your ADRC chooses to record multiple tests together, the interviewer initials, and other information that is helpful for the people who are processing and the researchers who are consuming this data as to like, was either the interviewer or the participant wearing a mask, and what was the setting, like to get a little gauge the noise level of the setting, the microphone location, and the recording device's manufacturer model, and so on. So lots of information. Again, please go to the NAC website where all of this information is there. And just wanted to end with a few helpful tips. So keep the purpose and the details general and non-specific in the IRB protocol to avoid limiting yourself. For example, use languages like, we'll be using recording devices such as, so that when you switch your recording devices, you don't have to make an amendment to your protocol. The privacy and security of the data should be protected the way you're protecting every other data from your participants, whether it's like MRIs or like genotyping information or any other type of data that you're collecting from your participant. So we of course have to have locally stored and HIPAA compliant storage solutions, and access, you want to keep it limited locally to IRB approved study staff, and then transmit it securely to NAC. And then meanwhile, lots of effort from RODA and NAC in how to de-identify and make sure that this data can be securely analyzed. So while we are waiting for some of those things to be finalized, we're just very excited that you have the option of starting to collect this data and with the metadata forms that we've designed as soon as NAC UDS4 is live. So I will stop there and thank you.